Good morning. Yay. Now, wonderful. Awesome. And we are recording. Very good. Very good. It is exactly 9 o'clock. Perfect. So I want to give people a minute or two to join, but welcome. How are all of you guys? Good afternoon. If you don't know me, my name's Amanda. I've been a NICU nurse for about 15 years. I'm a neonatal clinical nurse specialist in Southern California at a level 4 NICU. And I just consider myself a forever student. I love to teach, I love to learn, and I've taken a lot of certification exams, starting with my RNC-NIC back, I think that was in 2012. Then I've gotten my CELBW, CNNIC, the CNS one, the NPD one, the ONQS one. So I've taken a lot of certification exams. So I feel like I'm in a good position to help you guys pass your certification exam. I want you to succeed. And more importantly, I believe in you. I know that you can succeed. So I'm so happy that you are here. You guys ready to get started? Let's do it. All right, starting with question number 1. Oh, didn't change. Okay, question number 1. The best location for the pulse oximeter during neonatal resuscitation is A, the right hand or wrist, B, the right foot or toe, or C, the left hand or wrist. All right, so let's talk about this question. So whenever I'm teaching NRP, I always like to ask my students, whether it's my NICU team or I teach our postpartum nurses, or even sometimes our docs, our fellows, our residents, and I talk about, okay, where does the pulse ox go during neonatal resuscitation? And people are always quick to tell me preductal, right? Preductal. But what does that mean? And so it's important to know, yes, we want to put the pulse oximeter in the preductal location, but why do we want to put it there? And so if you think about it, if we're picturing the heart, and it's nice because I have a picture here whenever I'm teaching NRP, I'm always like drawing on myself. But so we have our heart here, right? And we have the big candy cane shaped artery, our aorta, that branches off of our left ventricle. And from there, there's these 3 arteries that branch off, right? So there's the right subclavian, which bifurcates to become the right carotid. And then we have the left carotid. And then usually, every baby is a little different. We all have our own anatomy. But typically, right around that area then is our ductus arteriosus. And then is the left subclavian, right? And so we know where the ductus arteriosus is, there can be mixing of oxygenated and deoxygenated blood, right? And so our deoxygenated blood can just cross right over from the pulmonary artery across the ductus arteriosus and start mixing around here. So all this blood that's flowing up from in the preductal area, so before the ductus arteriosus, to the right subclavian, right carotid, left carotid, what is that perfusing? That's perfusing our brain, or our baby's brain, right? And as well as the coronaries, which branch off really way further down here at the very beginning of the aorta. But that's important because we really want to know how much oxygen is getting to that baby's brain while we're resuscitating them. So that's why the correct answer is A, the right hand or wrist, right? So good job for all of you guys that said A. That's awesome. Any questions, feel free to ask in the chat. I have it here so I can see it. But we'll move right along to question number 2. All right, so number 2. You are caring for a patient requiring prostaglandin E1 for a ductal-dependent cyanotic congenital heart disease, or defect, excuse me. What side effect are you monitoring your patient for? So A, apnea, B, hypertension, or C, hypothermia? Have any of you guys taken care of babies with complex congenital heart disease and had to start PGE? Let me give you guys 30 or so seconds to take your guess. All right, so let's talk a little bit about PGE. What is prostaglandin E1 or PGE? So it's indicated to promote that dilation of the ductus arteriosus in our babies with complex congenital heart disease that is dependent on that ductus for shunting of oxygenation, or shunting for either oxygenation and or perfusion. So, and I always like to think about, we have circulating prostaglandin in our bodies. That's we have that already. And when we have certain conditions, like say, we have a fever, we have a headache, we take things like acetaminophen, we take things like ibuprofen, and that reduces the histamine. It's like a histamine blocker, but also it reduces that vasodilation that occurs from the naturally occurring prostaglandin in our body. That's one of the things I think about. But in this case, this is a type of prostaglandin that we are giving to promote vasodilation. And so we are giving, our initial doses are anywhere from 0.05 to 0.1, and then we're going to wean it down for a maintenance dose, which can be as low as 0.01 mics per kilo per minute, because the higher doses we give, they can cause a high incidence of adverse effects. So what are some of those adverse effects? Well, we can have babies who become apneic, they'll stop breathing. They can become hypotensive, they can have fever and flushing. And that kind of makes sense, right? When you're thinking about prostaglandins cause vasodilation, we have a lot of vasodilation, we can have hypotension because now there's a lot less afterload for that heart to pump against. Flushing, bradycardia, and then these ones are, I don't feel like we see as commonly, but still good to know, leukocytosis, hypokalemia with prolonged therapy, or even gastric outlet obstructions. So thinking back to our question, what did it ask us? Apnea, hypertension, or hypothermia? So those were kind of flipped. So apnea is for sure the answer. So good job, everybody that said A. B is not correct because we don't see hypertension. We'll see hypotension with baby who has PGE. And then C, hypothermia, it's the opposite. We see hyperthermia, we see fever, we see a baby who gets really, really warm. Does the certification exam ask about normal dosing? That's a great question. I've never seen an RNC style question that's asking you, what is the dose of PGE? Because really, when we're caring for our patients, it's within our scope to, go to our micromedics or our lipping or whatever, you use Neofax to validate the dose, but we're not prescribing. So they're not going to expect you to know just off the top of your head, what are the doses of PGE? Great question. Okay, awesome. One other thing I actually forgot to mention that I meant to when it comes to all the NCC exams is that the way that they order the answer choices are always going to be in alphabetical order. So I try to model that in my questions as well. And I think that's good to know just because I don't know about you guys, but I remember being in like elementary school, taking like standardized tests. And if the last three were all C, for example, it's like, oh, it can't be C again. Like, I think it was just like a myth, but just to not have that in your brain at all, because that is how they randomize the answer choices, is they put them in alphabetical order. All right. Let's go on to question number 3. So you're called to a delivery of a term newborn with gastroschisis. Which of the following special considerations should be utilized when resuscitating this baby? So what do you need to think about when you're resuscitating a baby with gastroschisis? A, ask the OB provider to leave the umbilical cord 2 to 3 centimeters. B, place a lower extremity peripheral IV as soon as possible for fluid resuscitation. Or C, position the baby on the right side to optimize bowel perfusion. All right, let's talk about gastroschisis. Has anyone been to a gastroschisis delivery before? So what is gastroschisis? Gastroschisis is this defect, it's an abdominal wall defect where the bowel is protruding outside of the right side of the umbilicus. It's almost always going to be on the right side. Very, very rarely it can occur on the left side, but those cases are really, really more abnormal. So we don't totally know why this happens. There's theories that it's type of vascular defect. Really early in embryology, there's actually 2 umbilical vessels, and they think that perhaps maybe one of them kind of has some sort of vascular accident that causes this opening in the abdominal wall, but we don't really know. Compared to other abdominal wall defects like omphalocele, gastroschisis has a lot less associated anomalies, but the one that you do need to know about is bowel atresias. So there can be bowel atresia, and here in this picture from the NRP textbook, you can see the atresias in this bowel. Okay, so what do we need to do if you've ever been in like a delivery for gastroschisis? What is top of mind for us? So one of them is we want to ask the OB provider to leave the cord long. So clamp the cord anywhere from 10 to 20 centimeters. And that's because the pediatric surgeon sometimes will use the cord for the repair. It's pretty cool. Basically, what they can do is they bring the bowel back into the abdominal cavity, but they actually use the umbilicus to kind of act as like I almost think of like fascia, like it's covering it, and then they put a dressing over it. I'm probably way oversimplifying it since I am not a surgeon, but it's kind of cool. So they'll use the cord for the repair. We want to place the baby in a bowel bag or a sterile clear plastic bag from the feet up to the axilla, right? We want to protect that bowel. We want to try and reduce that evaporative water loss. We want to make sure that we can see the bowel. We're going to position the baby on the right side to optimize perfusion. So if you imagine this fetus that has gastroschisis and they're in utero, the bowel is just kind of floating around because they're in amniotic fluid. They're suspended in water. Once they're born, gravity is pushing against them. And if they're laying flat on their back, that bowel can just fall to the side. And all the little vessels that are supplying blood flow to the bowel can be kinked. So we don't want those to be kinked. So we put the baby on the right side, or if they are supine, we have to make sure that that bowel is well supported. Okay. We're going to avoid prolonged bag mask ventilation because we don't want to over distend the bowel. And we're going to insert a large OG tube to decompress the bowel, put that to low intermittent suction or low continuous suction, because sometimes they can have a lot of amniotic fluid like coming out of their mouth too. So we want to make sure that we are decompressing that bowel. We're going to minimize handling of the bowel, but we need to monitor for signs of poor perfusion. And so that's where that clear plastic bag is important, that we can see that the bowel looks well perfused and it's not becoming cyanotic or anything like that. And of course, we know that there's increased heat loss, increased fluid loss. So we have to closely monitor temperature and we need to initiate fluids promptly. These babies are going to need higher total fluids, but we don't want to start a PIV in the lower extremities. So if you think about after we bring the baby to NICU and the surgical team comes, either there's going to be the primary repair where they push all that bowel back into the abdominal cavity, or they place a silo. Either way, there's a lot of pressure in that abdominal cavity on that inferior vena cava, which can cause a type of compartment syndrome. And if you're trying to infuse fluids from the lower extremities up towards all that pressure, you're going to have a problem. So we need to avoid the lower extremities when we're placing that PIV. So when we're looking at our question, we know that for A, that's a little too short, 2 to 3 centimeters. We want it to be longer, so we can say A is not it. For B, we know that we do want to start fluids as soon as possible, but not in a lower extremity PIV. So we can get rid of B. So C is the answer. So yay, everybody that said C. Good job, guys. How's the speed? Am I going okay? Am I going too fast? Let me know. Any questions about gastroschisis? Otherwise, we're good. Okay, we'll move on to the next question. So question number 4. You are resuscitating a term newborn after an emergent cesarean section for prolonged fetal bradycardia. The newborn is intubated and has been receiving chest compressions for the past minute. The heart rate remains less than 60 and epinephrine is indicated. What is the correct dose of epinephrine for this 4,000 gram newborn? So we have A, 0.04 milligrams, which is 0.4 mLs of 0.1 milligrams per ml solution epinephrine via the endotracheal tube. We have B, 0.08 milligrams, which is 0.8 mLs of 0.01 milligrams per ml solution epinephrine via IV push, followed by a 1 ml flush. Or we have C, 0.08 milligrams, which is 0.8 mLs of 0.1 milligram per ml solution via IV push, followed by a 3 ml flush. All right, so let's talk about epinephrine. So first of all, when is epinephrine indicated? So per NRP, if the heart rate is less than 60, after at least 30 seconds of positive pressure ventilation that inflates the lungs, as evidenced by chest movement, so we want to see that chest rise, right? And then another 60 seconds of chest compressions that's coordinated with positive pressure ventilation using 100% FiO2. If we've gone through all of that and our heart rate is still less than 60, then that baby needs epinephrine, right? And in most cases, the vast majority, ventilation should be provided through a advanced airway, either an endotracheal tube or a laryngeal mask airway. So that is our indications for epinephrine. Now, let's talk a little bit about the dosing. So I wanted to point out the concentration. So 0.1 milligrams per ml or 1 milligram per 10 ml is what you'll see on the box. I still hear a lot of times people talking about 1 to 10,000 dosing, 1 to 10,000 dosing, which is that old language of that was our dosing, that was our concentration. But in 2016, the pharmacy people changed the concentration from a 1 to 10,000 to a 0.1 milligram per ml, just to align with how we do most of our medications. So I want to highlight that just so that you know, because I always worry about, being in a code and somebody saying, is it 1 to 10,000? And you're looking at the box and it's not going to say that on the box. It's going to say 1 milligram and 10 ml and then 0.1 milligram per ml. Now, how can we give epinephrine? We have two routes in an emergency. So we can give it through the intravascular route, meaning through an IV or through an IO. I have to say I've never used an IO in the delivery room, but it is, there are studies on it, or through an endotracheal tube. Now, through the IV, that is the preferred method, intravascular route, and our dosing is 0.02 milligrams per kilo, which is 0.2 mLs per kilo. We know that it's preferred because when we give a medication IV, we have 100% bioavailability. We know that 100% of that medication is getting to that intravascular space. But we also know that in this last edition of NRP, they told us to give a higher flush, so a 3 ml flush, because when they did some studies, they saw that when you give your epi and then you follow with only 1 cc, that not all of that epi is going to make its way to the heart. And thinking about, how much volume does it take for us to flush a UVC, for example, I can't remember off the top of my head, but let's just say 1.5, then you have to make sure that not only your medication gets out of the catheter, but it also makes its way through the ductus venosus into the IVC up to the heart. So we have to make sure that we have that 3 ml flush. Then our other route is through the endotracheal route, and this is a larger dose because when we're giving a medication endotracheally, especially in the DR, we really don't know how much is getting absorbed into the vascular system. We don't know if the lungs are open. We don't know if there's fetal lung fluid. We don't know how much is going to diffuse across into the capillary space. So endotracheal is recommended only while we're trying to get vascular access established, right? So let's talk about our baby. So our baby's weight was 4,000 grams, which we know is 4 kilos. And so our IV or IO dosing is 0.02 milligrams per kilo or 0.2 ml per kilo. So 0.2 times 4, right, is 0.08 or 0.8 mLs, rapid IV push followed by a 3 ml flush. Or if we didn't have vascular access, we would give our 0.1 milligram per kilo or 1 ml per kilo via the ET tube. So 4 mLs, 1 ml times 4 mLs via ET tube. Make sense? So for me, knowing my concentration is 0.1 milligram per ml, especially with these emergent meds, I like to just kind of remember the volume because that's what I'm drawing. That makes it a little easier for me in my head, so I'm not doing all these calculations. So 0.2 ml per kilo for intravascular route, 1 ml per kilo through the endotracheal tube. All right, so let's look at our answers. So we know that it's not A because 0.4 mLs through the endotracheal tube is not enough. This baby would need 4 mLs through the ET tube. So we can cross out A. We know it's not B because this is 0.8 mLs followed by a 1 ml flush. So little details sometimes can trip us up. So making sure to notice, like these two are almost exactly the same. What is different? This one is only 1 ml flush compared to a 3 ml flush. I think NRP is one of those things that's very, very relevant to know, of course, for our job as well as the certification exam. Okay. Any questions on epi? If not, we will move on to question 5. You are caring for an ex-27-week preterm baby boy who is now 4 weeks old. He's 31 weeks corrected. And upon your exam, he is hypothermic. He had bilious vomiting and bloody stools. And he was made NPO to rule out A, necrotizing enterocolitis, B, pyloric stenosis, or C, spontaneous intestinal perforation. All right, let's break this one down together. So first thing, looking at this, we have NEC, we have pyloric stenosis, we have a SIP. Right away, I can say it's not B because this baby had bilious vomiting. And with pyloric stenosis, what do we see commonly with a baby with pyloric stenosis? We see projectile non-bilious vomiting, because when you think about where's the pylorus, it's between the stomach and the duodenum. And where is bile coming from? It's coming from the ampulla of Vater, which is further down, right? And so if it's an obstruction before the ampulla of Vater, you're not going to have bilious vomiting. So just with that, we can knock out B, which means now we have a 50-50 chance. We have NEC and we have SIP. And so it's like, okay, what is the difference between necrotizing enterocolitis and spontaneous intestinal perforation? So we can look at them together. Both of them primarily affect preterm babies, but with necrotizing enterocolitis, we see a lot of feeding intolerance. We can see the bloody or mucousy containing stools. We see abdominal distension, which I feel like who don't we see abdominal distension in, especially if you use a lot of non-invasive support. But here's a big thing is this usually occurs at a peak of 29 to 32 weeks corrected gestational age. And I don't know if you guys listen to the Incubator podcast. I really love the Incubator podcast. They had a journal club, maybe it was a few months ago now, that looked at a group who looked at a retrospective review of their babies with necrotizing enterocolitis. And they found that the vast majority of them had NEC around this time frame and around, I think it was like 4 to 6 weeks of age. And so that is a big thing. The other thing thinking about necrotizing enterocolitis is it's this major inflammatory event, right? So these babies are super sick. Whereas babies with spontaneous intestinal perforation, again, they're preterm babies. They have this bluish discoloration of the abdomen, but they oftentimes may not appear as ill. They can have this free air, but no pneumatosis on their x-ray. And they have this early in the first 1 to 2 weeks of life. So those are some of the big differences that we can see with necrotizing enterocolitis and SIP. I remember there's a few babies that I can think about that had SIP where it was like the air was caught just on an x-ray that was just checking placement of a line. And it was surprising to everyone because the baby was acting totally fine. Or another baby who had just the slightest bit of like discoloration that we didn't like to the abdomen, and the morning x-ray showed free air. And so again, surprising to everyone that the baby is very stable most often, but has this perforation. So, and it does make sense when you think about NEC, they have this major inflammatory event. So they are sick versus SIP, where they just have this spontaneous perforation. So with that, we can knock C out because this baby was an X27 weeker. He's now 4 weeks old, 31 weeks corrected. So good job. I think all of you guys got that one. So yay, awesome. All right, let's move on to question number 6. Okay, now we're getting to the genetic stuff. So osteogenesis imperfecta is an autosomal dominant disorder. What is the likelihood that an affected parent would pass the gene to their child? Is it A, 25%, B, 50%, or C, 100%? Awesome. Okay, so let's talk. Have any of you guys taken care of babies with osteogenesis imperfecta? I've only had 2, I think, in my career. So it's not super common, but we can see it. So osteogenesis imperfecta, there's actually a lot of different types of osteogenesis imperfecta. And I didn't even realize how many types there were until I was preparing for this talk. And it's basically, there's this defect on genes that encode different collagen types, and that contributes to the ability to build bone and to have these strong bones. And so these babies with osteogenesis imperfecta, they are characterized by having really fragile bones, so much that sometimes when they're born, they can have fractures that are in multiple stages of healing. Interestingly, when I was reviewing it, they didn't find that vaginal delivery was any more risky than C-section. So they still recommend vaginal delivery. But other very interesting assessment things that go with OI is blue sclera, which is fascinating. I can't recall if the babies I took care of had this or not, but blue sclera is one. And then they can have short stature because of the impact on their bones. And things that are really important for us as the nurses who are caring for them in the NICU is that they require very gentle handling and a lot of pain management with all those fractures. But the handling, we really have to be so careful that like when we're picking them up, that we're really supporting their head and neck, because if their head tilts just a little bit, they could have fractures. Or when we're changing their diaper, that we're doing it in a way similar to the way we think of when we're caring for our babies who are extremely preterm, and we're trying to avoid IVH, that we're not lifting the legs in a way that could pull, that could cause a fracture, that we're just being extremely gentle. So OI, the more common types is autosomal dominant. And who loves genetic stuff? I know a few weeks ago, maybe it was a few months ago now, I wrote like a genetics blog for everybody. And I had to really dig deep because genetics just doesn't come easily to me either. So with osteogenesis imperfecta or autosomal dominant types of defects, there's one mutated gene. And since that one, we only need to give one mutated gene to our children for them to be affected in autosomal dominant. And so when children are born to a parent, one parent that's affected, they only need to receive the one gene to become affected. So they have a 50% chance. So each parent will give one gene to their child. And if the non-affected parent, they give one gene, right, then there's only a 50% chance that baby could be affected. So of the two genes that the affected parent could give, if that makes sense. So autosomal dominant inheritance patterns, there's a 50% chance that the child will be affected. Autosomal recessive, even smaller, there's a 25% chance, and that's for each child. Okay, so some other examples of autosomal dominant disorders is like polycystic kidney disease or Noonan syndrome or neurofibromatosis. Autosomal recessive, the big one I always think about is cystic fibrosis. Okay, so those are some good things to just kind of know, those inheritance patterns. What is the likelihood if it's autosomal dominant or autosomal recessive? All right, moving on to question number 7. What lab finding would you expect in a patient with acute kidney injury? Would you expect an elevated serum creatinine, decreased blood urea nitrogen, or hypercalcemia? All right. So let's talk a little bit about acute kidney injury. So acute kidney injury happens when there's this abrupt decrease in the glomerular filtration, the functioning of the kidney. And we can often see that with diminished urinary output. So the urinary output goes really low, and elevation of serum creatinine. And AKI has different stages of injury. And so here you can kind of see, and it's looking at the degree of change from baseline of the serum creatinine and how much urine output are we getting. So from 0 to all the way up to stage 3 of AKI. Now, we can also see, in addition to the elevated serum creatinine, some electrolyte abnormalities. But when you think about this, sometimes you could think like if the kidneys aren't functioning, they're not filtering the way they're supposed to. These are babies who can get really kind of puffy. They can get really edematous and asarchic. And so instead of seeing high levels of electrolytes, you might see low, like hypocalcemia, because they can get diluted with all of that fluid that's not being excreted the way it's supposed to. So that's one way that you could think about it. Also with the blood urea nitrogen, typically you'll see that be elevated as well as the creatinine. But truly, AKI is identified with high creatinine levels and low urine output. Okay, all of you guys got that one right, so that's awesome. Moving right along, question number 8. You're caring for a term newborn who required positive pressure ventilation and intubation in the delivery room after a prolonged late decel. The first capillary blood gas obtained in the NICU shows a pH of 7.15, CO2 65, PO2 35, bicarb 15, and base deficit of -8. The best interpretation of this blood gas is it A, metabolic, B, mixed, or C, respiratory? All right, who loves blood gases? Who loves blood gas interpretations? Let's go through it together. There's a lot of different ways to do blood gas interpretation. I personally like to kind of use this kind of box model where you do arrows, but other people like to do other things. Whatever works for you. There's the great nomogram from the Stable program, whatever works. So we look at our pH, 7.15. Our normal is 7.35 to 7.45, so we know that is low. Our CO2 is 65, normal is 35 to 45, so we know that is high. And remember, CO2 is an acid. The only way that we can excrete CO2 from our body is through exhalation, breathing. So we know that there is a respiratory component to this blood gas. And then our bicarbonate, normal is 20 to 26, and ours is 15. So bicarbonate, if we don't have a lot of that, that's not a lot of base. So the low amount of base is also contributing to this acidosis. So we have both respiratory and metabolic contributions to this acidosis. So we know that it is a mixed acidosis. And so this is a type of baby I think of like, oh man, like was there some sort of a, prolonged late decel? So you think, could this baby have some degree of HIE? What were the cord gases? I don't know. So thinking about things like that. Good job, guys. All right, question number 9. Your patient is on high frequency oscillator and you notice decreased chest wiggle. This could be due to A, an airway obstruction, B, high amplitude, or C, pulmonary interstitial emphysema. Who feels really confident about vents and vent settings, high frequency settings? For me, it took me a really long time. So let's briefly just talk about the oscillator. So the oscillator is a type of high frequency ventilator, right? And we know high frequency ventilators, they provide really rapid rates with really small tidal volumes. And so we think that those could be, more gentle to the lungs. And the high frequency high frequency oscillator, it provides active inspiration and expiration. So when we think about this little, I can never remember what it's truly called, but it's kind of like a drum. When we think about that, that is pushing and pulling with each of those Hertz cycles, each of those little breaths. So it's active in, active out, push, pull, push, pull, push, pull. And it's doing this with this constant descending pressure. So our mean airway pressure. So we have constantly distended lungs. So they're always open. And these little vibrations that's causing this push, pull, push, pull, push, pull from the oscillator, right? So just reviewing our different settings, our frequency or our Hertz it's captured in cycles per second. So that's where we get, if we have a baby on a Hertz of 10 cycles per second means that we have 600 breaths a minute, right? So that's really fast, and active breaths. So preterm babies, typically it's, 10 to 15. Term babies, typically a little bit lower, 7 to 12. And the amplitude is actually how inflated the lungs are and how much of that chest wiggle we see. That's what's contributing to ventilation or our exchange of carbon dioxide, right? There's no true set number, but typically what the team will do is they'll say, okay, let's take the map times 2 and it's plus or minus 2. So if the map was 10, they could go up to 18, see if there's a good chest wiggle, 20 if there's not, even up to 22. And then last is our mean airway pressure, which is that constant distending pressure. And that is what's controlling oxygenation. So when we're thinking about the way it works, if we need constant descending pressure for this wiggle and we don't see the wiggle, what could be causing that? Why would we see that? And I think all of you guys quickly got it. It's not going to be high amplitude, because if we have a really high amplitude, the baby's wiggling like crazy, right? They could be wiggling off their little bed. So it's not high amplitude. And then C, pulmonary interstitial emphysema, that's like an air leak. So that's when the gas is actually escaping out into the little like airways or the little areas outside the alveoli and creating this air leak. So we know if we're not seeing a wiggle, there might be an obstruction somewhere to our airway. So we would want to, especially as nurses, rule out that and make sure that our airway is clear. And all of you guys got that one really quick. So yay, good job. All right, this is our last question. We have flown through this really good. Number 10, septic shock falls under the category of, is it A, distributive shock, B, hypovolemic shock, or C, obstructive shock? All right, let's talk about the different types of shock. So we have cardiogenic shock, which is, or actually first, let me just say, what is shock, right? Shock is the physiological state that's characterized by inadequate tissue perfusion to meet the metabolic demands of the body, right? So we don't have enough perfusion to our tissues. We're not delivering oxygen to those tissues. And so we're not meeting the metabolic demands of the body, okay? So different types of shock. So we have cardiogenic shock, which happens when there's reduced cardiac output, and that can be secondary to abnormal cardiac function or pump failure. So common causes of cardiogenic shock are congenital heart defects, arrhythmias, it could be myocarditis, or it could be sepsis. But sepsis or cardiogenic was not one of our responses. So what else do we have? We have hypovolemic shock, which occurs due to inadequate intravascular volume. So that results from fluid losses, which causes decreased preload and cardiac output. So largely you can think about, fluid loss from, vomiting, diarrhea, things like that, or blood loss. I always think about, subgaleal hemorrhages or umbilical cord accidents or things like that. So hypovolemic shock, we don't have enough circulating volume. Then there's obstructive shock. So something that's physically impairing blood flow. It's physically impairing venous return. So for that, you can think of things like a pericardial tamponade or a tension pneumothorax that's actually pressing on the SVC and the IVC that it cannot deliver. Or you can think about ductal dependent congenital heart diseases like a coarc, right? If the coarc is obstructing the aorta, then everything below is not able to deliver perfusion to those tissues. And then we have distributive shock, which is reduced systemic vascular resistance, which causes this maldistribution of blood flow and blood volume. And septic shock is the most common form of distributive shock. And when you think about it, you can think when our body goes into sepsis, the capillaries become super permeable. And that is so that all of those different inflammatory markers, our cytokines and our complement and all of the things and our toll-like receptors, all of those things can travel the neutrophils to the area of infection and destroy it. And so those capillaries intentionally become very, very permeable. But not only those infectious markers will cross that, but so will blood flow. And so when babies are in septic shock, they don't really respond great to volume. And what we see is they become super edematous. We can see third spacing. And so usually babies in septic shock need, after we volume resuscitate, they often need inotropes or vasopressors to actually support cardiac function because of that reduced afterload or that reduced systemic vascular resistance. So they need something to help with that vasoconstriction. So good job to all of you guys that said A. That one is a good one to know too, just because like when you're taking, whether it's PALS or the RNC or whatever it is, it's like they don't just call septic shock, it's distributive shock. So I hope that these reviews of these questions were helpful for all of you. I hope it helps kind of see what the exam questions are like and how to kind of look at the questions and the answers and break it down to help you identify the correct answer. For those of you who are studying and who are trying to become certified, I have something special for you. It's almost the holidays, and so I've been working to put together this Black Friday bundle. And so it includes my certification success course, which has 13 lessons on demand, recordings of lecture style, as well as lots of practice questions for you to practice, as well as I bundled that with the recordings we had a study group over the spring and summer that was a lot like this, a lot like what we did today, where we looked at 30 questions for each session and broke them down just like we did today. So it was a lot of Q&A time and a lot of breaking these down together. But I wanted to give you guys more because like I said, I believe in you guys and I know that you'll succeed and I want to help you as much as I can. And so I also created 10 like flashcards that is really practical things. It's like the most common cause of early onset sepsis, the most common infectious thing, like things that I think are high level, things that you should just know, but also things that are good for the certification exam. So there's 100 bonus flashcards, but you guys may or may not know in the certification success course, there's also a lot of flashcards through Quizlet that you guys get access to. Plus, over the past month, I was working on different case studies. So I created 5 case studies so that you could take a lot of this RNC style knowledge and put it towards a case study so that you can take it and make it practical to what do I need to do as a NICU nurse on a day-to-day, right? So all of that together typically would cost you like $300-ish, $327. I want to give it to you guys for $207. So it's like a 30-ish% off for Black Friday. So you can scan the QR code. I'll also send you guys the link. This will be available to you through November 30th. And when you pass your exam, whether you get the Black Friday bundle or you were just here for the 10 questions we did, let me know that you passed so I can celebrate with you, because I get so excited. It makes my day when on Wednesday mornings I wake up and I have my coffee and I do my morning routine. And then I look at my Instagram and I see people say, Amanda, I passed. Amanda, I passed. And it makes me so happy. So thank you guys for being here. Tell me, what questions do you have about anything, about the certification, about the Black Friday bundle, about NICU in general, about anything? What questions do you guys have? Do you find out if you pass right after the exam? That's a great question. No. So years ago, they used to print it out, but they changed the way they do it, where they have to validate to make sure that you pass. So typically what you'll see if you log into the NCC website the Wednesday after you take your exam. So if you take it on Thursday, then the following Wednesday, you log into your exam. And if you passed, your card is typically there. If you took it Monday or Tuesday of that same week, I think you have to wait until the next Wednesday. I don't think it's that quick. So great question. Yeah, you don't know right away. And so I know it's so hard because it's like, you're like, I just want to know how I did. I have a lot of people who reach out to me after they took it and they're like, oh my God, there's no way. That was so hard. And I tell them, I bet you did better than you thought. And a lot of times then the Wednesday, they're like, I passed. And I'm like, yay, we're celebrating together. What advice would you give a new NICU nurse? For a new NICU nurse, I would definitely say, I recommend that as you're caring for your babies, go look up whatever it is that whatever condition they have. So if they have RDS, go look up RDS. If they have a pneumo, go look up the pneumo. Look up every single med that you're giving them. That way, as you're going through it, it's really integrated into your brain. Do you offer any study material for the CCRN? So the CCRN and the RNC really follow very much the same types of topics and categories. The biggest difference about the CCRN is they have 4 answer choices compared to the RNC's 3. So I have had nurses who took my course and they passed the CCRN as well. It's just largely geared towards the RNC because I find that more nurses from the NICU do that. But the CCRN definitely is a great magnet recognized certification, and this course also will help you with that too. Okay, well, if there's no more questions, then I look forward to seeing you guys the next time. If you think of questions, feel free, email me or message me on Instagram. I'm here for you. Like I said, I believe in you and I believe in your ability to succeed. So thank you for being here and look forward to my emails where you will get the slides and the recording. Thank you. Have a wonderful day.